Good morning, everyone. You are very welcome to the HSE Healthy Weight for Children annual learning and sharing event. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using any other device today, you may find this feature located at the top of your screen or where there's 3 dots. Now, without further ado, I will hand you over to Dr. Abigail Collins, National Clinical Lead, Child Health Public Health, HSE. Thank you.
Good morning, everybody. You're very welcome to this morning's webinar. Delighted to have so many people here joining us for this, what's becoming an annual online shared event, which I think is so beneficial to us all to come together to think about all the work we do for Healthy Weight for Children, to think about it in the context, I suppose, of what we can do and deliver as services, to think about what we can do in the kind of broader environment, and to learn from some of the really, I suppose, poignant and sharp research that's being undertaken internationally or nationally, and that can be applied, or we should consider how we can sort of translate into our regular settings. So delighted to have everybody here. We've got a full agenda for this morning's webinar, so I'm going to go straight ahead and introduce for this first morning's session. We've got 3 speakers, and I'll introduce them one by one. Thanks very much to all of our speakers for joining us. And I'm going to go straight over to Geraldine Sexton, who, as many of you know, is a Colliery registered dietitian, and she works for the Healthy Eating Active Living programme. And she's going to provide us with an overview of resources developed for the HSE to support parents when introducing family foods. Geraldine, you're very welcome. Thanks very much.
Thanks, Abigail. So I'm just going to share my presentation. Can everyone see that? Okay, so good morning, everyone, and thank you for being here today. I'm really excited to share with you the suite of resources the HSE have been developing and continue to develop as part of the Healthy Weight for Children Action Plan. So these resources are designed to support parents and caregivers during one of the most important stages, weaning their baby onto solid foods. But before we dive into the resources, let's take a moment to talk about why weaning support matters and why this stage is so critical for infant health. So let's start by looking at why the first 2 years of life matter so much. So this is a period of rapid growth and brain development, but it's also a window where we can really influence long-term health. What babies eat in these early years can help reduce the risk of obesity, type 2 diabetes, cardiovascular disease, and even iron deficiency. And importantly, their early food experience shapes their long-term eating habits and food preferences. So what exactly do we mean by weaning? So weaning is simply the gradual move from breast milk or first infant formula to solid or family foods. And it's not just about nutrition, it's a developmental process too. So during weaning, babies learn how to chew and swallow, they develop hand-eye coordination as they start to feed themselves, and they begin exploring different textures and tastes. So all of this lays the foundation for independent eating and positive mealtime routines. In terms of guidance, both the WHO and the Food Safety Authority of Ireland recommend exclusive breastfeeding for the first 6 months. Weaning should then start around 6 months unless a healthcare professional has advised otherwise, but it shouldn't begin before 17 weeks. And breastfeeding can continue up to 2 years and beyond if it works for the family. So by the time babies reach 6 months, their nutritional needs have changed. So breast milk or the first infant formula alone can't provide everything they need anymore. They require more energy as they become more active, more protein for growth, essential fats for brain development, and key micronutrients like zinc and vitamins A and D. Iron becomes especially important at this stage because the iron stores they're born with are usually used up by 6 months. And low iron can affect both cognitive and motor development. And that's why offering a variety of nutrient-dense foods like your pureed meats, your pulses, and your vegetables is so important because these foods support healthy growth and development. Weaning also has a big impact on taste preferences. So babies naturally prefer sweet and salty flavors. So what we offer them really does matter at this time. So starting with simple, savory, nutrient-dense foods helps set a lower preference for sweetness and saltiness later in childhood. Breastfed babies might already have been exposed to different flavors through breast milk, but introducing solids or family foods gives an even bigger opportunity to broaden their plate and helps them accept a wide range of foods. So let's look at what is happening in Ireland. So research shows that current practices don't always match the recommendations. Some babies are weaned far too early, sometimes before 12 weeks. And by 6 months, many babies are regularly having foods high in sugar, fat, and salt, like biscuits, crisps, chocolate, and fizzy drinks. A lot of commercial baby foods, even though they meet regulations, can still be high in sugar or fat. These habits contribute to rising childhood obesity rates. And obesity is a real issue here. The latest COSI report highlights this. They've found that 70% of primary school children in Ireland are living with overweight or obesity. In DEIS schools, that rises to more than 25%. So if we want to put that into perspective, in a typical classroom of 30 children, about 6 will have overweight or obesity. And this isn't just about physical health, it affects mental health too, as it can lead to stigma, bullying, and anxiety. So as you can see, this is a critical period, not just for nutrition, but also for shaping lifelong health. And it's an opportunity for us as healthcare professionals to support parents by helping them build positive feeding practices early on, so we can promote healthy growth, support development, and set children up for healthier eating habits throughout life. So now that we understand why weaning is important and we have a sense of some of the current practices here in Ireland, let's take a look at what parents themselves are telling us about their experiences. So the first big challenge the report is confusion and inconsistent advice. So parents often get mixed messages from healthcare professionals, from family, friends, and even from the baby food companies. This can leave them feeling unsure about when to start, what foods to offer, and how to progress with weaning. Some parents even say the advice they do get feels poorly timed, and it can be either too early or basically they're saying it's not reinforced when they need it the most. Next, there are practical challenges. So parents worry about things like choking, allergies, portion sizes, or whether the child is eating enough or too much. And of course, cost and time pressures add extra stress, especially for families under financial strain. Social influence or networks also play a big role. So advice from grandparents and peers can be both a help and a hindrance. Some parents value traditional advice while others dismiss it as outdated. Peer comparisons as well, so seeing what other parents are doing, can also create pressure to start solids early or to offer certain foods. Another common issue is the reliance on commercial baby foods. So many parents trust the labels, assuming these products meet all nutritional needs. But some of these foods are high in sugar or salt, and marketing can strongly influence the choices parents make. Finally, parents express a strong desire for more information. In fact, 82% say they want clear, practical guidance on weaning, things like portion sizes, how to progress with textures, and managing allergies. So these are the realities that parents are facing, and understanding these barriers helps us to design better support and resources that actually meet their needs. So let me give you some examples of what that actually looks like in practice. So clear, consistent, evidence-based messaging is key. This helps reduce confusion and ensures families get the right advice at the right time. Strengthening support structures builds parents' confidence and reduces the stigma that sometimes stop them from asking for help. Engaging workshops and interactions can better reach and support parents, especially in disadvantaged areas where the need is greatest. Practical skills training, like preparing low-cost, healthy homemade meals, gives parents alternatives to commercial baby foods, and it boosts their confidence as well. Standardized training for healthcare professionals ensures that every parent receives consistent, high-quality guidance no matter where they live. So these actions come directly from listening to parents and understanding the real challenges they face. And by addressing these, we can make a meaningful difference in supporting families through the weaning journey. And that is what we've been trying to do. And when I say we, I mean the HSE. Now, before I show you the resources that we've developed based on all of these, I want to talk about the approach we use when prioritising and designing them. And that's something called progressive universalism. So what does that actually mean? Well, it's a principle in public health that says services should be available to everyone, but the level of support should match the level of need. In other words, it's universal but proportionate. And the reason why we use this model is because health inequalities don't just affect the most disadvantaged, they exist across the whole population. If we only target the most deprived groups, we risk leaving others behind and even creating stigma. On the other hand, if we only provide universal services without extra help for those who need it, the gaps stay the same. So progressive universalism combines fairness and inclusivity. It gives everyone access but scales up support where it's needed the most. And why does this make sense for weaning? Well, every parent faces challenges during weaning, but some families experience more barriers, things like cost, access to advice, or influence from marketing. So by using this model, we can make sure all parents get clear, evidence-based guidance while also providing extra support for those who need it the most, like tailored workshop and resources. This way, we're not just helping individual families, we're reducing inequalities and supporting healthier outcomes for all children. So this here is what the model of progressive universalism looks like. We have it here as a pyramid. At the base, we have the low intensity, broad population support available to everyone. And then as we move up, the support becomes more targeted and intensive for those who need it most. The idea is that parents and families can access a level of support that suits their needs. So now we'll have a look at how the HSE is using the model to support weaning practices in Ireland. So level 1 is the broad population approach, and this is about making evidence-based information available to all parents. So examples include the My Child 0 to 2 book and the mychild.ie website, both of which empower parents during these critical early years. We also have the HSE YouTube channel, which has a weaning playlist. So following a co-creation process during 2023 to 2024, we've been able to add 10 more accessible weaning videos to our YouTube playlist. These are some of the video titles here. So we have ones on getting started, signs your baby is ready for weaning, introducing food allergens early, responsive feeding, and foods to avoid. So that covers foods that are unsafe for babies under 12 months. We also have videos on common myths. We also have a lot of meal prep demonstrations in the playlist. So in total, we now have 18 videos, which, as you can see, all offer practical support to parents and caregivers when weaning, some of which have been kindly shared by Safe Food. Now, creating the videos is only half the job. Getting them seen is just as important, and that's where the HSE Digital and Comms team comes in. So they've developed a dedicated social media campaign to make sure that these videos don't just sit on a website, they're actively reaching the people who need them. And the reason we prioritize social media this time is because that is where parents are getting their information from. They want something that's quick and accessible. So by using these platforms, we can start to share those short, engaging content that fits into their busy lives. And it also allows us to keep the conversation going. So rather than just a once-off post, we can continuously reinforce the key messages over time. We also have the HSE podcast. So episode number 114 had Joanne Byrne, community dietitian, talk about weaning with confidence. And in this episode, she talked about how to start weaning, the signs of readiness, first foods and textures, balancing milk and solid foods, managing refusals, gagging and constipation. So these are the topics and the questions that parents are mostly asking us. So as you can see, we have developed a range of resources to meet different learning preferences. Some people prefer reading, others prefer videos, and some like to listen on the go. So by offering all these formats, we're making sure that the information is accessible in the way that works best for every individual. Now, building on these resources for parents and caregivers, HSE Health and Wellbeing, led by Maeve McGuinness, are developing a suite of e-learning modules specifically for early learning and care practitioners. These modules expand on previous Healthy Ireland Smart Start programme, but they've been adapted for online learning to be more accessible and flexible for busy educators. So these modules are going to support early years educators, which also includes childminders, in embedding health promoting practices into daily provision, covering nutrition, physical activity, and emotional well-being. Focusing on the nutrition modules, the content in the module provides information from birth to 5 years, so it includes information on weaning and is based directly on the nutrition standards for early learning and care service developed in 2023, along with other key guidance documents. Beyond direct parent resources, this level includes broader food system work like the Food Reformulation Task Force. So this task force, led by the Department of Health and FSAI, is working to reduce sugar, salt and saturated fat and energy in foods that contribute most to the Irish diet. In 2024, the task force introduced specific reformulation targets for food marketed to children under 36 months, which are in line with Ireland's infant feeding guidance. So that's no added sugars or sweeteners, strict sodium limits, and maintaining saturated fat goals. You'll hear more about this in a couple of presentations. Well, what's important to know is while that work is progressing, parental education remains key to promoting healthy choices. These commercially made baby foods are not going away, so we need to be able to make sure that parents are supported with the practical skills to give their baby family foods, but if they're going to use these products, that they know how to do it safely. So all of the resources that I've mentioned so far do that. And finally, breastfeeding promotion up to 2 years and beyond is also a core part of this universal approach. Level 2 then is increased support. So here we move to more personalised help. So public health nurses deliver the Universal Child Health Programme, and the routine 3 and 9-month checks are a great opportunity to provide extra weaning support for families who need it. Public health nurses are supported with training and resources like the Nutrition Reference Pack for 0 to 1-year-olds and the Healthy Child Programme e-learning modules. They also have access to specialist supports like dietitians or other specialist service if referral is needed. Finally, we have level 3. This is the most intensive level where we focus on targeted supports. For example, the Introducing Family Foods to Your Baby workshop is designed for parents in Sláintecare healthy community areas. It can be delivered in person or online, depending on local needs, and will be delivered by public health nurses and dietitians. We piloted this workshop in CHO 1, 3 and 5 from September 2024 to March 2025. Following the pilot, the workshop was evaluated and is now in the final stages of refinement and wider stakeholder consultation. We also have culturally tailored resources like the My Child book, which has been adapted for traveller parents and families, which also includes a section on weaning. Dr. Fiona Chansey is currently leading out on the development of a new resource to support parents and caregivers and centre managers within the International Protection Accommodation Service centres. The aim of this is to give food providers, be that the parent or the centres, clear practical guidance on what helps them navigate the challenges of communal living while still following the latest evidence-based nutrition recommendations. This resource will be translated into the 6 most common IPAS languages for children, as well as Russian and Ukrainian, to ensure that it's accessible to as many families as possible. While it focuses on childhood nutrition, it also includes a dedicated section on safe and appropriate weaning practices. So as you can see, this model allows us to provide universal support for all parents while scaling up help for those who need it most. It's about equity, inclusivity, and making sure every family has the tools to give their child the best start. So to wrap up, weaning isn't just about food, it's about shaping lifelong health by supporting parents and caregivers with clear practical guidance and scaling up help where it's needed the most. We can make a real difference to these children. These resources are here to empower families, reduce inequalities, and give every child the best start in life. And this is just the beginning. As we roll out these resources and workshops, we'll keep learning, adapting, and strengthening support for families across Ireland. Our shared goal is simple: healthier children, healthier communities, and a healthier future for all. Thank you for listening.
Thanks very much for that, Geraldine. That's a lovely presentation, and I know a whistle-stop tour through a lot of available resources and a huge amount of hard work, I'm sure, including for many of people in the audience here today. So thanks very much both for the work and for the presentation, and I'm sure we'll pick up on some of those points in the discussion.
Thank you.
I want to move straight on, if that's okay. I'm delighted to introduce our next speaker, who is Catherine O'Riordan. You're very welcome, Catherine. Thanks so much for supporting us. I know you do in so many of these pieces of work. For those of you who don't know Catherine, she is the Assistant Principal Officer from the Department of Children, Youth and Disability, and Catherine has a remit for the First 5 policy. So, Catherine, I believe you're going to provide an overview to us today on how healthy eating is promoted and supported across the early years in the education sector, and you're very welcome.
Thanks very much, Dr. Abby. I'm going to introduce you to our new preschool nutrition program, and it's called Bia Blasta, the Irish for tasty food. And I want to tell you about this new program because we're starting very slowly at one of the aims is about supporting children to learn about nutrition in their preschool years. So let's see if I can move my slides on. So Bia Blasta, the preschool nutrition program, is embedded in Equal Start. So I want to tell you a little bit about Equal Start very quickly. Equal Start's a funding model, and it has targeted 800 childcare services where the most disadvantaged children attend. So all children, but particular children experiencing disadvantage, need equitable access to early learning care and school-age services. And this is how we're trying to target these children as they attend preschool. The Equal Start uses an identification model developed by Pobble, and the identification model looks at priority cohorts, and these are Traveller and Roma children, the National Childcare Scheme sponsored children. We use the Pobble deprivation score, obviously children experiencing homelessness and children in the international protection system and beneficiaries of temporary protection. What happens is every year as children register for preschool, their parents are asked to fill out the ethnic identifier. We did this in collaboration with the Traveller and Roma organisations and other agencies across the state, and parents and organisations have been really positively engaged with this, and now we're able to identify where exactly children in these targeted cohorts are as they enter preschool across the country. And we've just redone this again in September for the second year, and it's really helping us to identify in collaboration with the Deprivation Index where the children of most need are going to preschool. So Equal Start has a number of universal actions, communicating with parents, the diversity, equality and inclusion guidelines, interagency collaboration, critical incident planning, etc. And then Equal Start also has some targeted measures at the level of the child. And this additional nutrition programme is one of these targets, running since October the 1st, so really new programme. Bia Blasta has targeted 624 of the 800 services in Equal Start, and that's because these 624 services have children registered for preschool. Services are still signing up. We're almost at 400 services in Bia Blasta at the moment. Services are asked to deliver a learning lunch during the preschool morning. They're being offered a grant of €1,000 for those who have very limited food provision at the moment. A pack of resources, which I'm going to introduce you to now. Dietitian, nutritionist is currently being recruited, and obviously this fits within the monitoring and evaluation framework for the Equal Start process. So the program pack, which is being developed, is being delivered next week to the Bia Blasta services, comes in a what looks like a box file, an A4 box, and the contents includes the nutrition standards that we just heard about, Meal Times, a book developed by Bernardo's, which is about the valuable learning opportunity that Meal Times offer. An introduction to Bia Blasta, a light meals and snacks ideas booklet developed by Healthy Ireland, and some very important food safety information, information about allergens, and our Safe Food Rufus hand washing storybook, also very important to our age group. This is the information that's in the pack. All of these resources are going to be made available on Nurturing Skills, which is the new dedicated CPD site for early years educators and childminders. Also, if anybody would like access to the pack after this meeting, we'll make contact, and you're most welcome, and we can send you links to all of these documents. As this program is being developed, and as soon as the nutrition dietitian is in place, we will be adding to the resources that are available for early years educators, for parents, and for childminders. We're very excited about the program. We're very excited about how it might develop, and what resources will be made available with training to go along with this program. We are developing the food safety information and the training that goes with this as well. I want to tell you some of the considerations that have arising from Bia Blasta. We're obviously in conversation with the Food Safety Authority. We've had very good connections with the school meals, the interdepartmental working group on that, to complement the work. Food Safety Authority, Safe Foods have been a great help and a great partner in this, and of course, great collaboration with the Department of Health and Healthy Ireland. We're talking about the necessity to register as a food business and the environmental health officers and the Environmental Health Service are helping us with this. Services who access the equipment grant get an additional amount of money for 2 staff to do the HACCP training, and we're talking to services about how this develop, and we're considering the sustainable access of the programme, including low plastic and low wastage, on Friday we've started to take photographs of some of the practice that's happening currently, and incredibly interesting to see how this programme is developing. So thank you very much for your attention, and later on we'll have an opportunity to discuss this programme more.
Catherine, thanks so much for that presentation. Really lovely to hear about the programme, and yeah, I'm sure there'll be some questions and we'll discuss it more in the Q&A component, but thanks so much for presenting that to us now. I think what we'll do now is move straight on to our next presentation, and then we'll bring all the panelists back together, because I can see some questions coming in, which is great to have that interest from the audience. So, but for now, I'm delighted to introduce Sinead O'Mahony, who is the Food Reformulation Task Force lead with the Food Safety Authority of Ireland, and she's going to provide an overview of the task force work to develop reformulation targets for commercially available complementary foods. So, Dr. Sinead O'Mahony, you're very welcome. Thanks very much.
Thank you, Dr. Collins, much appreciated. So I'm going to share my screen here and make sure everyone can see. My slides, okay. So good morning all, and thank you very much to the webinar organisers for the opportunity to present this morning on some work we're doing to stimulate the reformulation of baby and toddler foods, which we refer to as commercially available complementary foods on the Irish market. My name is Dr. Sinead O'Mahony, and I'm the Food Reformulation Task Force Manager at the FSAI. So I suppose just to begin with some context, what is reformulation and why are we pursuing reformulation? So reformulation is the process of improving the composition of foods or the nutrient quality of foods by augmenting their processing or nutrient content. And it's repeatedly found as a cost-effective measure to reduce the dietary intakes of nutrients of public health concern in population diets. And Ireland isn't alone in pursuing a reformulation programme. So over 100 countries, approximately 111 countries globally, have national policies, strategies and plans to implement food reformulation. And reformulation is identified as a WHO best buy intervention for the prevention and control of non-communicable diseases. So there's a really strong body of evidence supporting the effectiveness of reformulation of the food supply in improving population health. And in Ireland, reformulation isn't a new concept. So we've had a salt reduction programme since 2003, and that was implemented by the FSAI between 2003 and 2013. And it was effective in bringing down population salt intakes between about, the data we have is between about 2008 and 2022 using the National Adult Nutrition Survey 1 and 2 data. In 2013, the salt reduction programme was handed over to the food industry to continue with. And when the National Obesity Policy and Action Plan was published by the Department of Health in 2016, it outlined that Ireland would pursue a broader programme of food reformulation. So not just looking at salt, but at other nutrients of concern like sugar and saturated fat. And then while a subgroup of the Obesity Policy Implementation Oversight Group led by Professor Ivan Perry was developing the roadmap for food product reformulation, at EU level, a trans fat elimination regulation was introduced, meaning that by law, trans fats or man-made trans fats were being removed from our food supply across the EU. Really positive step at an EU level. So we didn't have to tackle trans fats in our reformulation programme. So then in 2021, the roadmap for food product reformulation was published, and it's within the context of that roadmap that I'm speaking about reformulation today. So when referred to in the context of the roadmap, what we mean by reformulation is improving the nutritional content of commonly consumed processed foods and drinks by reducing calories and their target nutrients, such as saturated fat, salt, and sugar. And in order to realise the ambitions of the roadmap, a food reformulation task force was established, and this task force is a strategic partnership between the Department of Health and Healthy Ireland, at the Department of Health, and the Food Safety Authority of Ireland. And we're a team of 6, and our role is to implement the roadmap for food product reformulation in Ireland, to drive and monitor food industry progress in achieving what is set out in the roadmap for food product reformulation, to complete stakeholder engagement and information dissemination. And what the roadmap is asking is that across the food supply, and we 40 priority food categories for reformulation, that the sugar content is reduced by 20%, saturated fat is reduced by 10%, salt is reduced by 10%, and calories is reduced by 20%. The roadmap also set out that targets would be developed for baby and toddler foods based on the FSAI's work in 2012 and 2018 that was led by Dr. Mary Flynn, who leads out on the Public Health Nutrition Policy team, and that we would address the nutritional composition and quality issues that were found with the products in this category. So the task force was given the mandate to develop targets for this category. And why did we want to target baby and toddler foods, or as we refer to them, commercially available complementary foods for reformulation? So they're targeted within the wider context of the reformulation program. I mentioned we 40 priority food categories and the percentage reduction targets, but we needed specific targets for baby and toddler foods. And we know in Ireland that approximately 11% of children aged 3 years are living with overweight, and 2.7% are living with obesity, and that this population group exceed health-based upper nutrient intakes for free sugar and salt. We also know, based on an analysis of our National Preschool Nutrition Survey, that some of these complementary foods contribute considerably to the intake, particularly of free sugars in this population group. And as Geraldine already really nicely outlined, it's a real priority for us to improve the diets of the population group under 36 months. They're a vulnerable group, and there's a potential for long-term adverse health effects because of establishing taste preferences for sugar and salt, including an increased risk of obesity and chronic disease in later life. So in order to realise, I suppose, that mandate, we were given to develop reformulation targets for this food category, because we were the first country to finalise targets for this category. So we didn't really have a roadmap or a blueprint to work with, but we were fortunate in Ireland to have a lot of documentation and information that we could base our decisions on. So we refer to our national healthy eating guidelines for 1 to 4-year-olds, best practice for infant feeding, the scientific recommendations for food-based dietary guidelines. We considered the European legislation for food, for baby and toddler foods, to make sure we were aligning with that. And then we also referred to the WHO Nutrient and Promotion Profile Model, which is the first profile model for baby and toddler foods. And we were able, I suppose, to learn from this. So we developed and published, we developed the targets, issued them for consultation in 2023, and then published the targets in 2024. And we've specific targets for salt and sugar. And then we also include a request to the food industry to rebalance the product portfolios towards appropriate baby and toddler foods and away from inappropriate baby and toddler foods. And these targets were circulated to the Reformulation Network in July 2024. So when we talk about this group of commercially available baby and toddler foods, we look at it across about 8 subcategories. And we've developed particular sugar and salt targets for these subcategories. We haven't included targets for energy or saturated fat. Energy actually isn't really considered an issue in these foods. Some of them are actually quite low in energy content, sometimes too low. And for saturated fat, we recommend that saturated fat should come from healthy sources in the diet. And then we also have a specific ask to the food manufacturers to rebalance their product portfolios away from inappropriate baby and toddler foods. And what we mean by inappropriate is food products that mimic foods on the top shelf of the food pyramid. So like crisps, biscuits, sweets, cakes and buns. And we know that there are products like this sold as commercial baby foods. And what we're saying is it's not really possible to reformulate them to be healthier. They're just going to be inappropriate as weaning foods. And we've asked the retailers to limit the shelf space that's given to these inappropriate baby and toddler foods. So as Geraldine mentioned, when she discussed these guidance, we have targets related to no added sugar. So there should be no sugar added to baby and toddler foods. We do make an allowance for pureed and macerated and mashed fruit and vegetables because of the textural requirements for this population group. We ask the industry to refrain from masking the flavour of less sweet or bitter vegetables with sweet vegetables and fruits, so that infants and young children get the opportunity for their palates to adjust to less sweet flavours. We have a specific target for total sugar, so no more than 15% of energy from total sugar for savoury meals and commercially available snacks and finger foods. And then the targets for salt is no added salt. There should be no salt added. And then where there is sodium present, it shouldn't be more than 50 milligrams per 100 calories and no more than 100 milligrams per 100 calories if cheese is named in the front of pack of the product label. We have, as I've mentioned, asked the retailers to limit the shelf space given to the inappropriate baby and toddler foods, and the manufacturers to shift their product portfolios to appropriate baby and toddler foods. So then as the task force, we complete ongoing monitoring on the composition of the food supply, and we use a variety of data to do this. So when we look at what's happening in the baby and toddler food space and their conformance with these targets, I've just pulled out some high level results. I haven't gone into a huge amount of detail. I'll share where additional information can be found. But if we look at the products on the market in 2021, the proportion of baby and toddler foods meeting the no sugar target was quite high in some categories, like the savoury meals, the porridges and the pureed pouches, but was low then in the confectionaries, the snacks, and the ingredients like stocks and sauces. And if we look at the proportion of baby and toddler foods meeting the no added salt target, we can see really good conformance across most categories, except for the savoury meals and the snacks and finger foods and ingredients like sauces and stocks. And then if we look at the proportion of baby and toddler foods meeting the total sugar target, so this is for the savoury meals and snacks and finger foods specifically, in 2017, 56% of savoury meals met that target. That reduced to 45% in 2021. There's definitely improvements that need to be made there. And for the snacks and finger foods, 53% of products met the targets in 2017 and 51% met it in 2021. We also have gone out to the market, sampled these products from the market and sent them for laboratory analysis, so we can confirm that the labels are accurate sources of information to base our monitoring on. And when we look at that data, we can see that, the mean total sugar content of a suggested serving size of confectionery, for example, is 7.6 grams. So that's empty calories, really, that these infants and young children would be consuming as part of their weaning. And that's why we're asking manufacturers to remove these types of products from their product portfolios. So in conclusion, for some categories on the market at the moment, most products meet the targets, but there's still room for improvement in several categories. And we could see a higher proportion of products in 2017 met the targets when we compared it to 2021. And we published our targets in 2024, so that's the situation we're planning to address. And there really needs to be concentrated efforts on the reformulation of these products. And so what we're doing to drive the uptake of these reformulation guidelines is ongoing stakeholder engagement. So we meet with the food industry regularly, and both retailers and manufacturers, one-on-one and through group meetings like one we held in September, where we provided an update on the priorities for reformulation in this food category. And we were joined at that meeting by Dr. Grace O'Malley, who also gave a presentation really explaining, why it's so important that we prevent overweight and obesity in this population group. And then we're completing ongoing monitoring. So in 2025, we collected all food product information for baby and toddler foods from the market again, as well as shelf space information from the retailers. So these are our monitoring assistants who were out over the summer doing the data collection. And in this picture, they're collecting the shelf space that's allocated to these baby and toddler foods in different retailers. And we'll use that information to engage with the retailers to ask them to reduce the amount of shelf space given to these inappropriate baby and toddler foods. So I presented some of our monitoring information in the presentation, and if you're interested to learn more about that, you can find it in our progress and monitoring reports that are published on our webpage. We do have an upcoming event on the 5th of December on reformulation, and that's in the Convention Centre in person. It's still open for registration, so if anyone's interested to attend, if you're interested to learn more about reformulation, you can attend the event. And we also have a network where we send out information and updates on the work of the Reformulation Task Force. And you can sign up to that network using the QR code here. So thank you very much for your attention. And I think we have time for some questions now. So I'll stop sharing my slides.
Sinead, that was a lovely presentation. Thanks very much. And thanks very much to all of the presenters for this morning's session. And I'm delighted to welcome back Geraldine and Catherine to the virtual panel, I suppose, the virtual sofa. And we've got a little bit of time for some questions and answers, if that's okay. And we've got some that's come in from the audience out there. So I might start with some of those, if that's okay. Some general points about will the recording of the session be made available afterwards? It will, and we'll get confirmation of what slides people are happy to share for everyone out there, because I think some people are busy trying to write, others hoping that they'll be made available the normal piece, but we'll try and share as much as we're possibly able to with audiences. So thanks for that. There was also a question early on, Geraldine, in relation to some of the pieces that might be available for direct provision centres and the My Child. They're not yet available, as I understand it, but hopefully will be in the early new year. Is that right, Geraldine?
Yeah, Dr. Fiona Chansey is overseeing those projects, so she's not here today, but she said if anybody wanted to contact her directly, she'd be happy for that.
Perfect. Thanks for that, Geraldine. And yes, if anyone wants to use the Healthy Childhood email address, that will come to us, and Fiona can link back in there. So then we've got a few questions for yourself, Sinead. I suppose a really interesting topic area, and one that I suppose picks up on a few different themes that I think sort of Geraldine mentioned in terms of weaning, and weaning being a time frame that's I suppose of some concern often to parents, just that kind of confidence piece of what to give, and it can seem quite attractive if someone's done that for you, and there is something that you can purchase. So I suppose a lot of work being done to give parents the confidence and how to support weaning, and that piece about it being a culture. But I suppose if they are going to go to the shelf, really interesting to hear about the food formulation work that's ongoing with yourself. I suppose just a question to start with, is that voluntary in terms of following those codes, or is there any enforcement down the line around that space?
Thanks, Abigail. So at the moment, the National Reformulation Programme is voluntary, and the work that we're undertaking under the roadmap has been extended until the end of 2027. So right now it's voluntary, but the roadmap does state that if sufficient action or sufficient progress isn't realised, that mandatory measures will be considered into the future. So that's what's outlined in the roadmap. Now, there are EU regulations in relation to the composition of baby and toddler foods on the market, but they are in need of an update. And so the work that we're undertaking will go towards improving the current situation. But there is a need to update, I suppose, the EU regulations in this space, and that's something that has been discussed in the past and is, I suppose, on the agenda of member states in relation to the legislative requirements around these baby and toddler foods.
That's great. Thanks, Sinead. So at the moment, as it stands, is there any way for parents to know what products are better meeting, I suppose, the guidelines and those which aren't?
So we aren't planning on publishing results at a product level. So all of our results, so as we collected data for 2025, and we'll be publishing then what's happened between 2021 and 2025 in Q1 next year. We don't do direct communication with the consumer. And Geraldine, you might want to come in on this as well, because it's, from our perspective, commercial foods should just be a small component of a weaning diet. We've been very careful in how we've gone about communicating these targets. We didn't really do a huge amount of media or social media coverage. We did very direct communications with the industry, because we wanted to avoid unintended marketing of these products in the process, because as I said, they should just make up, if they are used, a small component of the diet as needed. Geraldine, I'm not sure if you want to come in on that.
Yeah, in the research with parents, a lot of the time they rely on these products is because they're not confident that they themselves can prepare healthy meals for their children. And because the way the products are marketed, they believe that everything their baby needs is in that jar or in that pouch. And that is why they're going towards them. So it's, I think it's really important that we are, teaching parents and supporting parents and encouraging them to say that the food that you provide is good. We want these babies to be weaned onto family foods, the same foods that the rest of the family are eating. There are times where some of these products can be convenient in small amounts. And again, as part of all the weaning resources we spoke about, we're really highlighting that, again, family foods are the best, but if you are going to use it, we need to use them safely. So for example, we don't want babies sucking from pouches. We want the food to be put into a bowl and still use the spoon so that we can develop those skills. So yeah, I agree that we don't want to be promoting them, but at the same time, we have to acknowledge that they are there, and therefore we need to support parents in how to use them safely, and to, again, re-emphasize the family food that you're providing will give your baby everything that it needs. And signposting as well, because if the families aren't confident about the food they're providing in their own home, there are lots of resources out there to support families to, learn how to make healthy food easy and on a budget, etc.
Thanks, Geraldine. Yeah, I think that's really important. As Sinead says, and you've said yourself, products are available, but that's not what you want people to be using on a routine basis. You want them to have that confidence. So hence the whole suite of resources that have been put into place, which I think is excellent. And I suppose we have to keep listening to parents to see how those resources could be best tailored, best improved. And I suppose part of it is always going to be at that higher level in terms of affordability, in terms of access, so they can make good healthy foods for weaning. And then there's part of that kind of knowledge piece, and then the confidence. And I suppose it is acknowledging that around the time you're weaning a baby, is often the time that sort of teething might be starting, sleep might be disrupted, people might be having to consider returning to the workplace. So in the complexity and stress, I suppose, of parents' lives, particularly the first time round, where, anxiety is often around if you haven't been through that process before with another child and you don't have that sort of exposure and confidence from that first time, the concern around choking as well, when you have to introduce lumps and bumps, people often get very concerned about that, how we can manage and to support people in that context. That sort of confidence piece is really critical, isn't it? And Geraldine, in terms of the stakeholder engagement around that, has there been anything that sort of struck you that we could do better, or that was sort of new in the context of everyday living now that we hadn't considered in the resources? Was there anything unusual about that, or was it just more getting that reach to support parents?
I think it's getting the reach, and I suppose for healthcare professionals to be aware of this bank of resources that we have and be confident in signposting parents to where they need to go. What was interesting is that a lot of parents would actually say that when they start weaning their baby, they actually look at their own diet. And so we're very much talking today about weaning resources, but there are so many resources out there to support adults and programs to support adults. And it's even thinking outside the box that we need to be not just signposting to weaning resources, but when you have a family in front of you and you are, thinking about that person's individual needs, being aware of what else is out there to support them as a whole. Because if this is a window of change where they want to maybe, do an overhaul of everything, let's grab that opportunity and direct them to those things.
Absolutely. It's often a time where you can get people to consider and reevaluate, I suppose, from many different perspectives. And if you can get the family dynamic for nutrition, I suppose, in a different trajectory, then that's, I suppose, the real hope for everything in terms of the context of healthy food and healthy eating. And as you said, and I know I've already referenced it, but I think it's just such an important thing. It's eating, weaning food, it's about a whole culture. It's not just literally what you're putting in the mouth. It's how it looks, it's how it feels, the time you spend, and I suppose the context around that time that is so important for people and for children to have an early positive association and experience of. And I suppose, Catherine, that then extends outside of the house setting. So once we've moved on, I suppose, from the really early pieces and I suppose the really early weaning pieces, which often might happen exclusively in a sort of a household setting, children in greater proportions then rapidly start to enter sort of formalized childcare environments as parents go back to work. So food is obviously a necessity in that environment and a real opportunity as well, isn't it? So another lovely kind of program, I suppose, that you've been involved in and looking at. I'm wondering if you can pick out any pieces that, as I suppose you're developing out, that has surprised you or pleased you, I suppose, about how it's developed out. Anything you hadn't expected? I know you've been involved in so many lovely programs, so you must have what you expect to be a sort of trajectory, but hopefully there's always a few nice surprises along the way.
We've had some lovely surprises. We've had some really great wins with children with disabilities, autistic children having very restricted diets and then being in their preschool group. Maybe some of the fear has been allayed by them watching other children taste the foods, and maybe they've only touched the food for a couple of weeks. Maybe then they've smelt the food for a couple of weeks and then they've gone on to taste it. And I think that that's really, really interesting. I'm really interested in some of this conversation about where early learning and care services, creches and childminders can influence parents in terms of opportunities for healthy eating, how we can prepare children by having them taste, select, make good choices about food, and how then that can influence parents. I think there's lovely opportunities there. And I think in that piece about creating that culture around weaning, healthy, nutritious food being choices that children and parents make, I think that working together, we have a really great opportunity. We purposely put our Nurturing Skills website as an open access website. And I think that that's really interesting in terms of, while we don't want to bombard parents with information, and I think it's really good if we're all speaking the same message. And as Geraldine said, when parents are confused or are getting messages from various places, and I know social media plays a part in this as well, I think that we have a great opportunity if all of the educators, and no matter what their background, are giving those healthy food messages and giving children opportunities to make great choices. What we found is when children are given opportunities and learn about food, they do make great choices. So I think that that's really been wonderful for us to see. We had a lovely opportunity when we piloted the program, where educators themselves were saying things, now I wouldn't try salmon myself, so I wouldn't expect children to like that. Fish was the big issue. And when the children tasted it and they loved it, the educators then tasted it again. And I thought that was a wonderful thing. So I think we've loads of opportunities in influencing communities, particularly communities that might have less access to nutritious foods. So, I think there's great opportunities for us all to work together.
Thanks, Catherine. Yeah, I think that's right. I think there's huge opportunities, and it can give a lot of confidence to parents if they see what their child is happily eating in a childcare environment. I think that can often surprise parents. Being a parent myself, I've been surprised when you see some of the things that they have for their dinner and they've eaten it all, and you sort of think, I wouldn't have thought that, or they might not necessarily outside of the environment as well. So it's really important actually that, they have different environments that are catered to nutritional needs and opportunities to explore, and in that nice cultural package. I think we all agree, it's really nice to get that positive cultural engagement with eating and with food. And I can see some comments in the Q&A component talking around sort of family eating together, and how some of that dynamic is lost, and some of it through culture and a lot of it through practicality of people working shifts and trying to manage childcare, etc. So I suppose it's how we kind of promote and support in the context of that. And Geraldine, I'm sure some of the resources that are available support parents in terms of, batch making and batch storing, and how to safely kind of store for appropriately weaned food. So it's not something people feel that they have to do every single day, that they can do that, plan to do it, and it can do it in an affordable way in terms of buying the healthy products.
Yeah, absolutely. And even just going back to the comments on the environment, that is a big thing that we emphasized through all the different resources, especially the ECE e-learning modules. We're talking about mess is good. So if you look at your typical ad or short video, you have this pristine kitchen, this pristine baby, and it looks it just looks very fancy. And we've come back and said, mess is good. It's the baby needs to get in there, get dirty, feel the food. We're talking about modeling. We're talking about when you're feeding the baby, what's the best way to sit so that you're right in front of them rather than kind of trying to come at the side. So all that food modeling, the environment, the importance of mess, and how all this is important in the developmental phase has been included in all of these resources. And parent overwhelm has been a big thing, because when they're thinking of all these things, the batch cooking, can I do it? All of these different things. Some parents feel like they're not being listened to. So we've addressed that in the different resources. And with that, then we have given the recommendations. And we've been very lucky that Safe Food, again, they've also developed a number of resources, and they've kindly shared them with us. So when a parent goes into, for example, the YouTube playlist, we have all of the resources, all 18 videos, which cover everything you just mentioned in one playlist. So that's really handy for parents as well, because yourself, with these social medias, you can go down rabbit holes and get taken away. But this is all in one place, and it's credible evidence-based information, one at a time, one after the other.
Thanks, Geraldine. That's great. And I think the more we have those resources and the more we manage to, I suppose, have them in that format that's accessible to parents, particularly those who might, respond better to the different style of messages than sort of, the conventional text in a single place. I think that's where we've got the most to gain really from our work and our endeavours. Catherine, just coming back to you before we leave the Be a Blaster topic, just wondering around evaluation of the project and what your plans and I suppose what your hopes might be for it overall ultimately.
We have a monitoring and evaluation framework. We've tendered out for an independent evaluation. There's lots of learning. Mostly we'll be looking to talk to educators, parents and children because their views will be the most important. And so we have a plan for that. And we've just started to go out to take photographs, and we've asked the educators to direct us to their photographs and allow the children to take some photographs. So they're already coming in incredibly interesting. Speaking to one point about children sitting together and eating together with educators, setting the table, using real plates and cups, and also being allowed to cut their bananas, butter their bread, and also pouring water and milk. And those, those kind of experiences are learning experiences. They're wonderful experiences, but also really, really supportive of that family eating style, allowing yourself to eat from the shared bowl and make choices about when you're full. And I think that sort of learning is vitally important for children when we're talking about combating obesity. I think that, so we'll be keeping you informed, and also we'll be seeking feedback from parents as we widen the program. This, we'd hope, will eventually be a universally available program in preschools. We're also looking at that under 3 age group at the moment, in the possibility of those sessional under 3 services that are often in targeted communities. And what can we do about early tastes in those? And so we're looking for next September for those, who will keep you informed about that as well.
That's great, Catherine. A lot going on in this space, and great to hear. And I'm sure we might be inviting you back at some stage for feedback on the evaluation, because certainly sounds like it will have some really lovely, rich feedback from children and visual. Intrigued to see the children taking photographs. That's great. Thanks for that. And Sinead, can I just ask a question more for myself here, not through scanning through. I've been trying to sort of read the Q&As coming in and influence questions. This is really purely for me. How does stakeholder engagement in your sector work when you're going out to these big companies and you are trying to, I suppose, sell that it's better to, we need to have standards, we need to have things to meet the sort of nutrition profile that we want, when they're presumably thinking people are more appealed where they don't meet those standards, and therefore the purchases might be higher. How do those engagements typically go?
So we, I suppose, take a hub and spoke approach to stakeholder engagement. I mean, the food industry is so broad and there's so many actors. So we use a variety of approaches to engage, but on the baby and toddler foods specifically, we've done a lot of one-on-one engagement. And it is because of that reason we wanted to have very direct conversations and I suppose avoid unintended marketing around commercially produced baby and toddler foods. We've been very fortunate. We get really strong engagement, I have to say. I think there is an understanding and an acceptance in general that consumers want healthier foods, and particularly they want foods for babies and for toddlers that are appropriate for weaning. So there is a general acceptance of that. We are the first country to finalize targets for baby and toddler foods. So we're out there doing some of the learning. But we engage very closely with other countries who are working in this space as well. So the UK had draft guidance for a long time. It hadn't been finalised. They did finalise their guidance earlier this year, but we would have been communicating and learning from each other on what works, what doesn't work. So we do one-on-one stakeholder engagement. We outline what our asks are. We ask the companies to present back to us what they're planning on doing, what their reformulation pipeline looks like, when they expect products to come to market. And we've already seen some really nice examples of reformulation take place already in some products. And then we do group meetings as well. So we would, bring all actors to the same, or all stakeholders to this same meeting and outline where we're seeing progress, where we see there could be more progress or more attention, and ask, for focus to be put on that. And this year we did 4 of those. We call them category meetings, where we bring all manufacturers together in a certain category. And the category we got the biggest attendance for and the biggest interest in was the baby and toddler food. So I think there is, kind of a recognition of a need to work towards improving these products. And I saw a question come in about added sugars that I might, someone had asked, is the fruit powders and the different types of, kind of dried fruit and that included in, so these types of free sugars included in the added sugar definition, and just to say that they are. And so our added sugar definition aligns as well with the European Food Safety Authority free sugar definition, and it's outlined in the guidance document, but it is quite a broad definition of added sugars.
Brilliant, Sinead. Thanks so much for that, and thanks for asking just one of my pet interest questions. I appreciate that. And just as we wrap it up for our 5-minute comfort break, so I just really want to thank yourself, Sinead, Geraldine, Catherine, for lovely presentations, and for joining me for this panel discussion, and for colleagues out there listening, for that active listening. I can tell through all the questions coming in and the answering going on. So thanks for that engagement. Have a 5-minute movement comfort break, and we will be back for the next set of presentations. Thanks very much, everybody.
Thank you.
Welcome back, everyone. I hope you got the chance to stand up and stretch a little bit there. That was a really informative earlier session. So much information shared, and really, illuminating panel discussion. And thanks so much for all your questions in, and thanks a million to all the contributors, and to Abby for chairing so well. So I am delighted to welcome you to the second half of this morning's session, and we are going to have a presentation from Dr. Kylie Hunter, who is a research fellow and co-lead of the Next Gen Evidence Synthesis team in the University of Sydney. And Kylie is going to speak to us about the Top Child research, which was recently published in the Lancet. So we're really thrilled to have her here, and to get a really in-depth insight to that research that will inform a lot of our work for the next while. And following Kylie's presentation, I'll be delighted to welcome a number of people for a panel discussion. So we'll have Dr. Abigail Collins, Fiona Ward, who's the Nutrition and Obesity Lead with the Department of Health, and Dr. Aileen McGloin from Safe Food, as well as Dr. Karen Matvenko from UCC. So Kylie, I might hand over to you to get started, and really looking forward to hearing your presentation.
Right, just unmute. Okay, can you hear me?
We can indeed, Kylie.
Okay, and you can see my slides.
Yes, we can.
Excellent. All right, thanks so much for having me, for the invitation to present. So yes, I am presenting from Sydney, Australia. So it's a little bit later here. So if I'm not as sharp as I might normally be, I do apologize in advance. So yeah, very happy to present on Top Child, so parent-focused behavioural interventions for the prevention of early childhood obesity. This project spanned more than 5 years with more than 100 collaborators across 16 countries. So it's really great to finally get to the results part of this project. So I probably don't need to spend too much time on why early childhood obesity prevention is important. I think this audience is well aware. But just briefly, so childhood obesity is a major global health issue, and it's an issue from very early on. So globally, around 36 million children under 5 years are already living with overweight and obesity. And in fact, Australia is one of the worst countries, with 1 in 4 Australian children already having overweight or obesity by the time they start school. And I think it's a little bit lower than that in Ireland. I saw various statistics. I didn't know which ones were correct, but so yeah, and we know that high body mass index in infancy is a strong predictor of lifelong overweight and obesity. And of course, this comes with increased risk of negative health consequences, both physical and mental. And so there is a compelling argument to intervene early. And with this in mind, governments around the world have been investing into early prevention programs despite uncertainty about their effectiveness. So the Top Child collaboration sought to address this uncertainty. So we first of all developed a steering group. So the chair is Professor Lena Zeidler, who's now based in Germany, and I'm a co-deputy chair. And we're all based here from the University of Sydney or Flinders University in South Australia. And first of all, we conducted systematic searches to identify eligible trials. And so that included randomized controlled trials enrolling pregnant women and or their children up to the age of 1. And they were evaluating parent-focused behavioural interventions for the prevention of obesity compared to usual care. And they had to collect at least one weight-related outcome. And so we invited investigators from these eligible trials to join the Top Child collaboration, share their data with us, and also their intervention materials. So just briefly, this is the overview of our collaboration. You can see we also we had several trial representatives, an advisory group, and some consumer representatives. And I'll just note we did have an advisor who's on the call now, Karen Matvienko-Sicker from University College Cork, and we did have a trialist, Charlene O'Reilly, from Ireland as well. So the Top Trial collaboration set out to conduct 3 major projects. The focus of my talk today will be the project that I led, which is the individual participant data meta-analysis. And so the key objectives of this project were to assess whether these parent-focused interventions are effective in improving body mass index Z-score and behavioural weight-related outcomes at 2 years of age, and also whether effectiveness varies across subgroups defined by individual level or trial level characteristics. So briefly, the methods we used was individual participant data meta-analysis. And so this involves the central collection of raw data for each participant in the original trials. And we've got a little snippet here which illustrates what that looks like. So traditionally in systematic reviews, and they're accompanied with aggregate data meta-analysis. So this involves extracting summary data from publications to then get average effect estimates. In individual participant data meta-analysis, we obtained, as I mentioned, the raw data, and this has several advantages. Obviously, we have the most comprehensive and current data. We can do lots of different checks to verify analyses and findings. Harmonization across studies is a big one, which I think we'll talk more about later. And importantly, we can do more complex analyses. So we can see, well, do these interventions work differently in certain populations, such as those with socioeconomic disadvantage? So we pre-specified all methods in a published protocol and a statistical analysis plan. And then once trialists agreed to join the collaboration and share their data with us, it went through quite comprehensive checks. So we lots of data processing, checking and cleaning in duplicate by our team. We also developed an integrity tool. You may be aware that research misconduct and fraud is emerging, so we wanted to make sure that we could trust the data from these trials. So we ran this tool on them. And we also developed methods for individual participant data informed risk of bias assessments. And lastly, we assessed the certainty of evidence using the GRADE system. So our pre-specified primary outcome was BMI Z-score at age 24 months, according to WHO growth standards. And we also collected several secondary outcomes. We pre-specified some key secondary outcomes, so one for each of these domains. So across infant feeding, dietary intake, screen time, physical activity, sleep, and parent feeding practices. Just briefly, each outcome was analysed using a complete case 2-stage approach. I won't go into too much detail there in the interest of time. We pre-specified several subgroups, both at the individual level and also regarding the intervention or the trial level. And we also conducted several pre-specified sensitivity analyses, which I'll touch on more in the results, because I think that's the fun part that we all want to get to. So what did we find? So as briefly mentioned, the results were published. We're very happy to have them published in The Lancet very recently in September. So if I'll give an overview today, but if you're interested in reading more, please do check out this paper. I think there's about a 100-page supplement as well, where you can look through all the data if you want to. So we ended up finding 18 eligible trials that assessed our primary outcome. And of these, we were very happy that we were able to obtain data for 17 of these. So this represented just over 9,000 participants, or 97% of the total eligible participants. And these 17 trials were set across 8 countries, which notably were all high-income countries. you can see, yeah, so 7 in Europe, 7 in Australia, New Zealand, and 3 in the US. The median sample size of these trials was 533, and about 29% of the interventions commenced during pregnancy, and the remainder commenced after birth at a median child age of about 3.9 months. So just this table, don't worry too much about the detail, but it's just to demonstrate that in the children, the baseline characteristics were balanced across intervention control groups and within expected ranges. So the babies were born at term and had an average rate of about 3.4 kilograms. In terms of the carer, which, or the parent, which was predominantly the mother. So the age at birth, the mean age at birth was 30.6 years. Most of the participants were first-time parents. 70% were born in the study country, so the remaining 30% were immigrants. And around 30% had a level high school education or lower. So this is our primary outcome results. For those of you that aren't familiar with the forest plot, I'll talk you through it a little bit. So each row here is a trial, and in the black boxes for each trial is the effect estimate, with the lines either side representing a 95% confidence interval, and the dotted vertical line is the line of no effect. So you can see every single one of these trials crosses the line of no effect, and our overall effect estimate was we found no difference between groups on BMI Z-score at age 24 months, and this was high certainty evidence. So we conducted several sensitivity analyses, and our findings were robust to all of these. So it didn't matter what type of analysis methods we used. We incorporated aggregate data where we couldn't get the IPD. We excluded trials that had a high risk of bias, integrity concerns, conflicts, so on. And none of this made a difference to our results, in fact, in that there was no effect of these interventions on BMI Z-score. In terms of our subgroup analyses, again, there was no evidence of differential intervention effects for pre-specified subgroups, including priority populations. So we were a little bit surprised about this. So we looked at each of these sociodemographic characteristics and thought maybe we would get a differential effect for these groups, but didn't find that to be the case. Similarly, we didn't find any evidence of differential effects for pre-specified trial level subgroups. So it didn't matter if interventions were delivered face-to-face or remotely, whether they were individual or group, whether they commenced during pregnancy or afterwards, and how intense they were. You know, the shortest intervention was 2 days and the longest was 39 months. So, and that there was no dose response relationship. Just noting that there were some subgroups we really wanted to look at but could not analyse due to insufficient data or them just being too heterogeneous. In particular, race, ethnicity, was collected so differently across trials that there was just nothing really we could really do there. In terms of secondary outcomes, we had 31 eligible trials contributing IPD for just almost 29,000 participants. So it's a lot of data cleaning. And these 31 trials were based in 10 countries, and we had 2 upper middle income countries here with Brazil and Belarus, and the remainder were high income countries. So in terms of our key secondary outcomes, for duration of exclusive breastfeeding at 6 months, we found no difference in between groups. Similarly, no difference in vegetable intake per day at age 24 months. For screen time, there was a small reduction in the intervention group. So they watched about 9.5 minutes less screen time per day compared to controls. But we want to interpret that cautiously. Don't want to get too excited about this because we have got multiple testing issues to consider. We found no effect on physical activity per day at age 2, no effect on sleep duration, and no effect on parent feeding practices in the domain of control. So, in summary, the interventions did not change the BMI-Z score at 24 months. There was no evidence of effectiveness in any pre-specified individual or trial-level subgroup, and the primary outcome was robust to all sensitivity analyses. In terms of key secondary outcomes, the intervention did not change any of these apart from a small reduction in screen time at age 24 months. And for our other secondary outcomes, there were no differences between intervention and control for most of the others, with a few small exceptions. So why didn't these interventions work? You know, they were designed by experts in the field very carefully. And so, you know, there was a bit of surprise and disappointment that they didn't work. So we have a few possible theories, which we can perhaps talk more about with the panel, but there have been, you know, several recent advances in behavior change therapy theory and co-design science since this sort of first iteration of interventions, and maybe, you know, these may make these interventions more effective. But, you know, we did already have quite a diverse range of interventions, and our subgroup analysis didn't suggest that any intervention type worked better than others. Perhaps, you know, interventions were targeting the wrong age group. So we had a consumer panel, and they provide feedback that, you know, the first year of life can be an overwhelming and stressful time for parents, and perhaps it's not, they're not in the right headspace to absorb all this new content and engage in these interventions. Interventions might not be reaching the priority populations who need them the most. So we do know that obesity is a health equity issue, with socio-economic disadvantaged populations being at higher risk. But we did conduct a sub-study, and we found around half of the included interventions did target priority populations. However, their success in reaching these groups did vary. And we also didn't find any anticipated differential intervention effects across priority populations. Perhaps a follow-up was too short. You know, we went up to 2 years. Maybe they needed more time to be effective. But in a previous study of 4 trials that we looked at, in fact, the opposite happened. So the interventions effects faded out over time. And this one, I think, is probably, in my opinion, the main one. So I think it's just too difficult. Interventions are downstreams, and they rely on a high degree of individual agency. So they rely on families having the capacity, the resources, and agency to be able to make these changes. But we know, you know, obesity is largely driven by upstream environmental and socio-economic factors. You know, we live in a very obesogenic environment where it's very easy to make poor choices and very difficult to make healthy choices. So I think just briefly, I think I've got a couple of minutes left. Cut me off if I don't. What's next? So we're really pleased we had quite broad media coverage of the Lancet publication, reaching almost 1 billion viewers worldwide. And so we're really hoping to leverage, you know, this interest to make positive change. And I think the key thing is, the key message, you know, we can't just place the burden on parents and families to solve childhood obesity. We need to move beyond this and implement whole system level approaches to have any real impact. So we want environments that encourage and make healthy choices the easier choices. So I think just briefly, you know, there's the WHO Commission on Ending Childhood Obesity, which has some really great recommendations, encouraging a whole of government approach across all sectors, with some recommendations such as sugar sweetened beverage tax, stricter regulation of unhealthy food marketing. I think it's also really promising to see the previous speaker talk about the reformulation of these baby foods as well. I think we're a bit behind on that in Australia. And then, yeah, so this also aligns with the Island Obesity Strategy in terms of, you know, you have to engage all sectors. You can't just, because obesity is so complex and multifaceted, you know, it's not enough. There's not one single solution. We really have to intervene across sectors to enable to have meaningful difference. That's the Australian strategy. We probably don't need to look at that. So just lastly, our project 2, which took a deep dive into, what do these interventions actually involve? What behavioural change techniques do they use? What behaviours do they target? That's been published as well, if you'd like to check it out, in the International Journal of Behavioural Nutrition and Physical Activity. I want to acknowledge funders and supporters, and also all the contributions of our investigators. Without them, we could not have done this project. So really grateful for all their contributions, testament to the power of collaboration. And we do have a website as well, if you'd like to check us out. So thank you.
Thanks very much, Kylie, for taking us through through that detail. We were ourselves here in the HSE delighted to be connected in with Karen on the wider package of work around the looking at the standardized childhood obesity outcome measures, which the top child was feeding into, and yeah, I think it's similar to yourselves as the findings from top child started emerging, surprised, because a number of the trials and a number of the researchers and a number of the interventions that were included are ones we'd be familiar with and would have heard really good things about over time. So yeah, my sense is it was quite a really interesting piece of work to do, probably quite challenging in terms of people digesting the findings and coming to terms with it. So Kylie, I'm going to welcome to our panel, as said, Abigail Collins, who people would have met earlier, Dr. Aileen McGlynn, who's the Director of Human Health and Nutrition here with Safe Food in Ireland, Fiona Ward, who's the Nutrition and Obesity Policy Lead with the Department, or Policy Advisor, sorry, with the Department of Health, and Karen, whom you know as well. So Karen is works in UCC with. Apologies, Karen. Now I'm getting a blank on the school in UCC.
School of Public Health in UCC.
Yeah, great. Thanks a million. So guys, I might just come to you all individually for your I suppose your initial kind of, having heard Kylie's presentation, what stands out for you or stood out for you in listening to it. So Abby, I might start with you.
Thanks very much, Sarah. Yeah, thanks for that, and thanks for the lovely presentation, Kylie. It was great to hear it and see it, and I've read the work a couple of times and the publication, and I get something new from it each time, or I kind of consider again what it can mean and what we can take away from it. I mean, I think when I very first heard it, you sort of feel that slump of all that work you're trying to do. That's not what, be careful the questions you ask, I suppose, but it's great to know, always better. Knowledge is power, as they say, and we can seek to get it right. I think for me, the big takeaway piece is how much we do a lot to support parents, and that's right, and that's always right. And I think that this doesn't undermine that, is the important thing for me, but it maybe kind of tailors it a little bit, and also tasks us with actually going the other stream, which we also know is that it cannot all work on single person behavioural change or family unit behavioural change to conquer the obesity crisis globally. That has to be upstream of that. We have to consider the obesogenic environment and what we're doing about that to support families. So I think for me, it means there's sort of equal importance. We have to really work together collaboratively to see how we can, push the dial on the obesogenic environment. But we are always going to need to support families and parents. And I suppose, to me, what the research doesn't show is, I suppose, where we do nothing to support families, what would that look like? I suppose, you know, you kind of, you're looking at the question you're looking at, and, you know, so then you start to think of what are the other questions that we haven't looked at. And I suppose one thing I'd be interested to know from you, Kylie, is where do you think the big gaps are in what we could better understand, because you've got under the bonnet of the data, I suppose, more than anyone, and what's been included in the trials to date, etc. So where have we not been looking that maybe we could get some, you know, helpful information? But predominantly, it's to me that parents still need supporting whatever they do, but they absolutely cannot do it in isolation. So we really need to have some focus on those upstream pieces.
Yeah, thanks, Abby. I might ask Fiona and Aileen for their initial thoughts before inviting Kylie to respond to that, to your question there. Fiona and then Aileen.
Hi everyone. Thank you for that really lovely presentation, Kylie. One thing that stood out to me on the publication is the scientific rigor that was applied to come to these conclusions. And I see, Kylie, that you were awarded for best publication in Sydney this year. So well done to you and the team on that. I agree with Abigail. I think that the results, when you read them in the first instance, you're kind of overwhelmingly disappointed because of all the efforts that everybody within the health services are trying to, I suppose, manifest and improve public health in the main. I think what it does show is that what Geraldine alluded to maybe earlier is that approach of progressive universalism is perhaps what we should be really focusing our attentions on. And I do agree with your suggestions within the paper that, you know, interventions at an individual level in isolation and not looking at the bigger picture of looking at social and commercial determinants really is not effective. So, and I suppose from a policy perspective, you know, as you indicated in your presentation towards the end, is that there are strategies within the Obesity Policy and Action Plan taking a kind of a multi-sectoral approach, but we need to do more in that space. And hopefully with the next iteration, that will come to the fore in our new plan, which will be published next year.
Thanks, Fiona. Aileen?
Thank you. And Kylie, thank you for a wonderful presentation. And I'm probably going to echo some of what's been said already, in that I think when you first hear these results, there's almost a visceral response to that can't be right. That can't be right. Everything we know about good practice, the Marmot principles, the first 1,000 days, intervening early to impact over the course of a lifetime, this all seems like it's the right thing to do. So hearing that there actually isn't the impact, at least on body weight and some of the behavioral aspects of the children's lives, is really disappointing. And then of course you read the elegant discussion that you included in your paper around, you know, is it the right timing? Is it long enough? Are these the right population groups? And of course the key point that most of the contributors here have made around, you know, obviously intervening at an individual or family level isn't enough. And we have to turn our attention, as those working in public health or public health nutrition like myself, to wider factors like the food environment or the physical activity environment. So I think the paper maybe confirms a lot of what we already know, energizes us a little bit more to understand how we can better support parents and children, and certainly refocuses us on the wider environment.
Thanks, Aileen. And Kylie, I might come back to you just in terms of those responses from, particularly maybe the question Abby posed at the end of her her response there. If you would like to come back in and respond, or if Karen would like to join the debate.
Yeah, so I've made a few notes. Hopefully I remember the questions correctly. But yeah, in terms of the reaction, yeah, we saw the results and we're like, oh, have we done it right? Let's triple check, let's quadruple check. And then it was like, oh, how do we break the news to our collaborators, you know, because they've obviously dedicated so much of their career and time to these interventions. But and I think that's kind of why it was really important we were independent. So we weren't, the steering group weren't involved in any of the trials. We didn't have any sort of conflict of interest or bias, and the results were what they were. But we were really pleased that, you know, despite negative results, the Lancet was still willing to publish, because it is important, because we need to redirect our resources and funding, you know, accordingly. It's a very important point that we definitely do not want to take away support from parents. So we were quite worried that that's how this would be interpreted. That's not what we want. Parents do obviously need support. It could be, you know, a lot of these trials were in high income countries. So the background sort of standard level of support is already quite good. And so perhaps, you know, adding things on, there wasn't as much to gain. And yeah, so in terms of the gaps, so we are going to do our third project, which is looking a little bit deeper. We're going to pre-specify some hypotheses looking at some of the intervention components, behaviors targeted, and outcomes, and just see if there's anything that may suggest, you know, that there is more benefit or some benefit to, and if so, we know whether that's worth exploring further. But yeah, I think the key thing is parents still need support, but maybe we need to explore like schools and primary healthcare and these environments that children are and parents, you know, or children are growing up in, to have real change. Did you want to add anything, Karen?
Yeah, so just to say, I agree with kind of all of the comments that have been made so far around the importance of still retaining the support for parents and caregivers. I think some of my reflections on the findings, so my immediate reflection, as Aileen said, was visceral. And we, as the broader team, received the results kind of briefing late one evening, Sydney time, but Irish time. And I lay awake for quite a while before I could actually fall asleep based on the findings. But I think there is a lot of scope for the kind of inclusion and the targeting and the support for populations that we don't often reach. So I know that, you know, we did look at those within Top Child, and there's been subsequent work looking at the reach for priority populations, but we still do find that even when we try to engage with, you know, priority populations, underserved populations within research particularly, we tend not to do as great a job as we would like, being able to kind of support those groups. Another gap, kind of, I suppose, methodologically for me within the studies that we looked at was intervention fidelity. So how well interventions are actually delivered and whether they're delivered as they're intended to. And we weren't actually able to look at that within the Top Child paper because not a lot of the original trials looked at that. And I think that kind of ties back to the very first speaker that we had today around that inconsistency of messaging and the stress that puts on parents and caregivers. So making sure that intervention standardized messaging is delivered as we intend it to be, and that it is standardized and consistent across healthcare professionals, across the different environments in which it's received, is really important. And even though we have a lot of measures in place, we still constantly hear back from parents that they're confused, that things are inconsistent. So I think that there's a lot of scope there. And I suppose the final point kind of that comes back to me quite a bit is when the findings, and Kylie, you can speak to this maybe a little bit better, but when they were presented back to the consumer panel, to the patient public involvement panel, that there was a little bit of relief from the parents and caregivers on that panel, that it wasn't their fault and the amount of stress and pressure that they feel. And I think that there's a lot of kind of space for us to work in that, to also focus on the kind of the mental health well-being aspects of supporting parents in this space, as well as the intervention provision. And I think there's been a lot of kind of talk about that as well this morning, implied in across the different programs that are being run. So a lot of scope for us to keep improving from these findings.
Yeah. And look, and I suppose it is helpful in many ways, because the conversation has started here in Ireland around the systems approach, the whole systems approach, whether it's a kind of a macro country legislative regulatory level or kind of local whole systems, which is kind of more, within our communities, within particular spaces and places. So there's a question just there in the chatting from the audience in terms of, what do the panel think is needed here in Ireland to take that that whole systems approach forward. Where do we start? Where do we put our focus? I might start with you on that, Fiona, as you're knee deep in the work around the formulating the next obesity policy.
Yeah, thank you. So I have a couple of different thoughts, and I think, as already been indicated, there's no one size fits all to address the issue of childhood obesity. And I think that there's lots of different things that we can do to try and change that. And I think what's evident here today is that all of the speakers that have presented today are engaged with us in terms of delivering on the Obesity Policy and Action Plan already. But that's a 10-year plan that's coming towards its final year, but we've got so much more that we need to do. So just based on this study alone, I had a couple of thoughts. So what is really important around this issue is looking at surveillance. So when I talk about surveillance, I mean both from a population level growth monitoring perspective. So we do have monitoring within primary care at 2 different time points. We have the COSI data and we have the healthy behaviours in school-age children, reports. And we also have our national dietary consumption surveys, but we need to make sure that they continue and that they are done on a more frequent basis so that we actually have evidence to help shape and inform policy. In the same way as those tools, such as the food dietary surveys, help to educate us in terms of looking at the food reformulation and how, our food can improve from a nutrient profile perspective. So that's my first thought. My second thought then is around obviously the whole systems-based approach. The Healthy Ireland framework is trying to develop that approach by developing, say, the healthy cities and communities, looking at improving, the settings-based approach, so the healthy campuses, the healthy workplace, the healthy schools, etc. And then, and obviously then providing that equity lens, so trying to give additional supports to those who really need them. And I'm sure Aileen can talk about this in more detail because she's very involved in that type of work. And then the other thing that I really thought about was, obviously you've mentioned it, Sarah, is the regulatory piece. And we did have that called out in the Obesity Policy and Action Plan, but we need to do far more in that space, I think, for the second version. And that was very much called out through the consultation process that we had for the Obesity Policy and Action Plan. So trying to introduce regulation with a view to looking at, say, labelling, information, calorie posting, marketing restrictions, obviously with respect to the HFSS, and then obviously improving, say things like the school meal scheme, etc. So we know that there's a lot more that can be done in this space. And frequently when you go to any of these obesity conferences, everyone references the tobacco experience, and everyone suggests that we're kind of at the start of that process and we're like 40 years behind. But I do feel that that's where we are in respect to improving the food environment. I won't go on for too much longer. Just one more thing I wanted to mention. And just in terms of the communications piece, I think what we need to do as healthcare professionals, and it did come up, is that people do want to have evidence-based information. They want it to be standardized. They want to be hearing the same thing at the right time. But I think we really need to use the genius that is marketing individuals in how they deliver those subliminal messages throughout the life course. And I think that that's something that we should be looking at. We need to get better in that space by using people who really know what they're talking about and how, have that knowledge base that they will be delivering those subliminal messages to drown out the social media noise of people who don't really understand what they're talking about. So I'll stop there.
Thanks, Fiona. Quite a lot of food for thought there. Abby, Aileen, do you want to come in on either of those, any of those points, or add to Fiona's contribution?
Yeah, it's really interesting discussion, and obviously, Fiona, I'd be very aligned in kind of similar kind of processes and similar thoughts. I think with reference to the tobacco and scenario, I suppose I feel that's a little harsh that we're not so far behind, and it's, you could argue it's a more complex issue. Food is good for you. It's just the whole, whereas tobacco isn't. So, I do think it's a really complex sort of issue around around food and nutrition. That is more challenging, and it's more challenging today in the context of the noise of voices and opinions that exist in a way that when we started with the smoking and tobacco issues, that was far more defined to classical media, I suppose. So I think we are in a very different setting, and I suppose I'm not wanting to be depressing at all, but I think we've got to get over the hump of the kind of the AI piece and the information. I think that's going to get harder for us in the short term, not easier, just because getting that sort of true and trusted message out there is hard for people, and especially when they're not getting their information necessarily from a place, that you search the topic and you get information, and it's not always evident where you're getting that information from, but there might be a high trust that it's good. So I think that space will be harder to navigate for us in the shorter term. But I mean, I think we are getting to the point where there is broader understanding that we really have to look to these upstream measures to support the environment we want to be in. And I'm always shocked and disappointed at how much individuals, parents, when we go out to parents, they feel that it's their responsibility. And, it's, I suppose, if there is a positive from this work, it is exactly as you said, Karen, to sort of, that kind of relief to share with parents, look, it's not all about you. Obviously we want your key stakeholders in this, key players in this, but we need the world to be right for you, for it to be under your control in a way that it's not. So I think the messaging is going to be tricky in the shorter term, and we probably need to have some really open, kind of clear discussions on how we manage that. And I think you're right, Fiona, trying to harvest those who know best around getting messages out, and to try and get them to support us with those, how we can do that for those messages is really important. I think that's a kind of tricky first piece, but I think we have to shift the dial. We have to keep that conversation to the broader systems upstream regulatory place.
Yeah. And Aileen, I know Fiona hinted at the work that you do in relation to health inequalities and working with underserved communities. There's a couple of comments there into the Q&A about that kind of, what are our opinions on the key challenges in reaching and supporting these communities, and what actions will help address it, and also a wider comment in relation to, food and diet isn't necessarily the only issue or challenge that these communities are dealing with, and there's issues like housing, income security, issues like that as well.
I absolutely agree. The people in the most areas of most deprivation are dealing with multiple challenges at all times. And food, of course, is the most pliable part of the budget, and the one that does get squeezed when you have to pay your rent or heat your home or whatever the other pressures are going to be. So totally acknowledge that. I see some interesting work happening in Northern Ireland. And to your practical question, how does this get done? It gets funded. So on a council level, there are what do they call? They call them exemplar areas in Northern Ireland where they're beginning to take whole systems approaches at a very local level to try and address obesity in areas of deprivation. And I think that's really, really promising. And I know through the Sláintecare Healthy Communities, you know, that kind of thinking is also coming to Ireland. So that really, you know, makes me very optimistic about, you know, how we can help in a very targeted way. On our within Safe Foods work, we fund community food initiatives throughout the island of Ireland, and those are traditionally have been skills building programs, so capacity building programs at local level, helping people with food skills, shopping skills, and so on. And in the most recent iteration, which is just a year old, we also have a theme. We've always had a theme around the food environment, but that's much, much more challenging than running skills building courses. But this is mandatory now. And there is a beautiful array of innovative approaches to changing their own food environments coming from within communities themselves. So sometimes when you challenge communities to address their own needs, they'll come up with the answers. So I was at a presentation in Belfast just last week, and the unlocking piece for a community of primarily women, single parents, was to get bus timetables printed, because they lived in a relatively isolated area where they couldn't access supermarkets. And the community food leader printed bus timetables and did a company bus trip, not an accompanied shop even, got on the bus with these women, brought them to the supermarket and turned around and went back again. And that was the thing. You know, so I think sometimes we have to think more broadly about the needs. And I know a lot of this work is already going on in communities across Ireland as well. But those kinds of deep investigations and understanding of the target audience and what their barriers are, you know, are also part of this picture. You know, traditionally nutritionists think in harder terms around, you know, what did they eat and what were the outcomes, like body weight, for example. But sometimes it's a little bit you know, the real magic is something far more fundamental and maybe not as obvious when you first approach these problems.
Yeah, no, and it is definitely we're seeing with the Sláintecare Healthy Communities initiative that is, you know, Department of Health cross-sectoral initiative looking at broad health, improving broad health and well-being across a number of communities in Ireland, and there's a collaboration there where those geographies overlap with the community food initiatives. But yeah, definitely really innovative stuff, and it's kind of creating the space to step outside. In a recent session, we had a webinar like this. We had actually it was the Sláintecare conference, Fiona, that the department held a couple of weeks ago. We heard from a community who are, you know, they're basically working with the community to push and funding them to work with the professionals they need to work with to present an alternative plan to the local authority for developing the retail space in their community, to make sure that to shift the dynamic from what, you know, the council want, which is, you know, a convenience store, another convenience store, to, you know, a retail offering that will broaden and enhance the food environment in the area. So very novel, different ways of thinking, and like I do see some comments in here around other sectors working together, health working with other sectors, and I suppose it is one of the things that you know is really positive to see, Fiona, since I came into this space, that, you know, we have like Catherine speaking earlier there about the Bia Blasta program, which is, you know, owned by the Department of Children and Early Years sector, and they're really taking the initiative and doing the work for themselves with their own sector and driving that forward. And we see similar in other areas as well. So it is very much around, health in all policies, isn't it, to some extent? Okay, just Kylie, and Karen, can I come back to you just while I'll scan through the other questions coming in here. I suppose if you look at the top child results and taking on board, as you were saying, kind of they were quite surprising initially. What's happening now in terms of your own work to Kylie, you've brought your little friend with you. To develop a consensus around that kind of that space of standard childhood obesity outcome indicators, because ultimately, if we want to make an impact, as Fiona was saying, we need to look at our surveillance and strengthen that, but those are long-term pieces. What do we need to be looking at? What indicators should we be seeking to shape, to influence, to measure?
Yeah, I'm happy to kind of go first, and then maybe kind of to talk a little bit about the harmonization. So, I suppose kind of building on from the top child findings and from other kind of evidence and research that we've conducted in the space, that was one of the main limitations we were finding to trying to get a kind of a clear answer on what works or what doesn't, is that everybody is measuring different things in research and practice. So the group that I lead in UCC and a group that's being led from Flinders University that myself and Kylie also work with, we've developed what are called core outcome sets and are currently developing core outcome measurement sets that go with those. And essentially what they are a standardized set of the outcomes that we should be looking at when we're trying to evaluate infant feeding and when we're trying to evaluate childhood obesity prevention. And then in addition to the outcomes, so the what we should be measuring, we're trying to find the best ways to measure those. So in the context, for instance, of infant feeding, these include things like the duration of breastfeeding, and they include things like, the introduction, timing of introduction of solids. They also include things like the feeding environment. And then kind of in the older child group, they include also things like sleep, time spent in sedentary behavior. I won't go into too much detail on all of them. I'm very happy to share resources on them, but we have very clear kind of definitions of what all of those mean. That's all well and good. We have these kind of indicators that have been developed through evidence building, stakeholder engagement, and then consensus processes internationally as what are kind of agreed to be the most important things that we should be looking at if we want to kind of see how well certain programs or interventions are working. And now we're looking at the best evidence-based, but also the most feasible ways to measure those outcomes. So thinking about it in terms of research, but also in practice. So, if you have a busy healthcare professional who might want to capture some of this information, how they can do it kind of quickly and easily. And I suppose one thing that kind of is emerging from that evidence, particularly we're doing an awful lot of work with stakeholders and stakeholder engagement around this, and it ties a little bit into our conversation a moment ago, is the importance of language in terms of how we're measuring things. And it's something that perhaps we don't often think about. So we can measure these different outcomes, we can have things like questionnaires and online surveys and things like that. But often it can be kind of an interpersonal one-on-one, it might be a healthcare professional asking a caregiver. And what we're finding from our engagement with parents and caregivers is that language that we often think is innocuous around infant feeding is actually incredibly emotive. So we've gone to our patient and public involvement panel and we've asked them, which of these questions do you think is the best way to measure exclusive breastfeeding? And we've had the mothers ask us, well, what's the definition of exclusive breastfeeding? They've gone away and they've come back the following week, and we've had mums, say, I was actually incredibly upset because I had one bad night and I gave my baby, a bottle of formula milk, and that means that the rest of it doesn't count just by virtue of the use of the language. And we've had that in a few different instances. So maybe asking people, have you introduced these types of foods? And then they suddenly start to question whether they should have introduced all of the types of foods, or which foods are good or which foods are bad. So I think that there's a really important piece in thinking about the language that we're using as well when we're trying to evaluate our outcomes, and when we're speaking in general about these kinds of things. And we're also very much, and Kylie, I'll let you come in here, building on some of the challenges from Top Child in terms of, the types of data that we actually want to get, as well as the ways in which we're trying to get it. So maybe Kylie, you might want to speak to that.
Yeah, thanks, Karen. Yeah, so as I mentioned, there were 31 different trials that we had data from, and yeah, as you can imagine, the outcomes were measured in a lot of different ways, which made our job a lot harder. And I think so it just highlights the importance of having this standardization, first of all, to enable evidence synthesis, but also comparison. And so what we did, we followed quite an extensive mapping process of all the data that had been provided to us, sometimes with good data dictionaries, sometimes not so good, and mapping this to the outcomes that we had pre-specified we were interested in for Top Child, and then working on how we can standardize these. And so we held several workshops with experts in each sort of domain. So we had a diet one, breastfeeding, sleep, and so on, and just had discussions around, like, does it make sense? Like, if it, one serve of vegetables per week, how many grams is that? Because sometimes it's measured in grams per day, sometimes it's measured in portions per day or per week, and just discussing what is equivalent and across countries, and how people would interpret a portion so it was a lot of fun. It was quite challenging, but we got there in the end. But as I said, there were some outcomes that we did want to look at, and we just couldn't, because the data we couldn't do anything with them. So I think we're going to publish a methods paper around how to do this sort of harmonization. But ideally there would be standardization from the start, and then our jobs would be much easier.
Yeah. And it's complex, isn't it, really? And there's some commentary in here into the Q&A, like broadening the conversation out into even that, our the work environment has changed so much now. The majority of families in Ireland are two-parent families in Ireland. Both parents are working. We have, single-parent families where parents are working. Is that having an impact in terms of the food environment at home, the time available to parents, cost of food came up in the earlier discussions as well. So it's quite a complex in environment, and as you were saying there, Karen, then it's a really challenging time for parents, and everybody is trying to do their best, and we can sometimes inadvertently undermine that, and that language piece is so important, because as Geraldine was saying earlier, for parents to feel confident and feel comfortable hearing from health professionals, because there is so much competing narrative around. So I might just, we're coming to the end of the panel discussion, but I might just maybe come back to Aileen, Abby and Fiona. Just, I suppose, what would your take-home message be out of today's discussion?
I suppose mine is just more to do, keep going with, in terms of, I suppose, the policy change pieces, keep going with supporting parents, but trying to get that engagement and feedback into how we support them. And language always comes up, and I think that's a lovely example was given here, how important language is to families around food and babies and health.
Nice. Aileen, Fiona, which one of you wants to go next?
Maybe I'll come in if that's okay. I think when you put this discussion in the context of the previous discussion as well, there's quite a lot to be hopeful about. I'm thinking of Catherine's work to enhance the food environment in the preschool level. I'm thinking of Sinead's work to enhance the food supply for this population group. So while the results of this particular piece of work are not positive, it does give us lots of direction as to how to improve when we're intervening to support families. But not to forget that there's a totality here, and I'll go on and talk about the food environment a little bit more later on, but we've all pointed to upstream measures. And I think a policy environment that is very much primed to put the lens on that as we move forward.
Yeah, thanks a lot. And a final thought, Fiona?
Yeah, so I think that I would agree with Abby is that, yes, we've achieved quite a bit through the Obesity Policy and Action Plan over the last 10 years, but there is much more to do. In response to policy initiatives, and it kind of references the question that came in there as well, the ESRI did a piece of research for us last year, which tested, I suppose, the acceptable or perception of different policy initiatives. There was 12 different policy initiatives that were checked through a sample size of about 3,000 people. And interestingly, all of the policy objectives that were suggested were acceptable to the general population. So I don't think, again, it's another case for there's just no one quick fix. I think the sugar sweetened drinks tax that we have introduced in Ireland didn't translate in an additional cost to the consumer. So I think that's a positive thing. It did result in food reformulation or drink reformulation. So that has been positive. And it's also resulted in a reduction in sugar consumption over the lifespan of the tax. So we can take the learning from that when we look at other policy initiatives. So again, we need to just keep going with our multi-sectoral and whole systems approach to try and nudge everyone to achieving a better health.
Great. Thanks very much, Fiona. And Kylie and Karen, can I just say thank you very much for your time today, especially you, Kylie. Hopefully now you'll get to go and rest and get some sleep. And thank you so much for that. And just one, I suppose, as we wrap up this this section, I might just pull one really nice comment from the Q&A from our audience. Una McCarthy there making the point that from our discussion, the old saying holds true. It takes a community to rear a child. So thank you very much. And now I'm going to hand over to Aileen. Aileen, you're going to share with us some more information from the current food environment campaign.
Great. Thank you, Sarah. I just take a moment here to share my screen. And hopefully that'll come up for you. Great. Okay, so I've got 10 minutes. So this is going to be a flying visit and a short update on our food environment campaign, Building a Healthier Food Environment. I'm hoping that most of you will be familiar with it. We've been running it for over a year now. And now my slides aren't moving. In a second. Here. Great, I've got it. So I will very briefly tell you about the concept of the campaign. We've referred to the food environment several times over the course of the webinar already. And that refers to the food that surrounds it and how it influences what we eat. So we know that we don't have less willpower, different appetites or biology than previous generations, but we have seen dramatic increases in our rates of obesity, and our food environment has also dramatically changed during that time. So in effect, we are encouraged to eat unhealthily at every turn that we take. The vision for the campaign is that every child can access and afford healthy food wherever they live. So we are trying to set children up for a better future through this campaign. We've had some discussion throughout the webinar on attribution of responsibility. And this is one of the first campaigns in Europe, certainly the first on the island of Ireland, but also in Europe, to really try to raise awareness of the food environment as our first port of call. And part of that is to try to change attribution of responsibility. So I'm showing you our key performance indicators. That's the first one. Awareness of the food environment is the second. So you know, when you start working on these kind of campaigns, you've lots of ambitions around, you know, we're going to change policy on the digital food environment and the retail setting and school food and all of the different policies that you will be familiar with from the food environment perspective. But actually, it's very grounding when you go out to the public and realize that only 1 in 4 have ever heard of the food environment. So that very much focuses the mind on raising awareness as our first task. We also wanted to raise awareness of the effects of the food environment, and we wanted to raise awareness of how it can change and who can change it. So we've been running since June last year, and we've had 4 different bursts. The primary channel for the campaign is TV, but it also ran on outdoor billboards. And I'm sure you saw some of the social media posts which focused on real people, ambassadors showing how their food lives and how that looks, and experts who we called trusted voices who helped expose some of the food environment and how it affects us. So I'm going to show the TV ad briefly, and I think Jean is going to do that for me.
I see them everywhere we go. They're in the shops, the petrol station, and in the machines when we go swimming. All the sweets, chocolate, crisps, and fizzy drinks. When I see them, I want them all.
Our kids are surrounded by unhealthy food. We need to change this food environment to protect their health. Search Safe Food for more information. Brought to you by Safe Food.
And you'll see from the presentation there that we very much focus on the child's perspective and the child's eye view. And that's what we're trying to get across. I'm going to share with you now a few of the very top line results just to see where are we after a year of doing this campaign. And then I'm going to tell you a little bit about our citizen engagement work. So integrated into the campaign is our evaluation. We run an Ipsos survey on an annual basis to try and understand what impact we are having. And this is in Ireland and Northern Ireland, with usually a split of around 500 and 300 people in each jurisdiction. And here we have our first question: who has the main responsibility for food-related ill health? And we have our baseline data there on the left and our 2025 data on the right. And we wanted to shift the dial on parents being responsible, and you'll see that that has gone down by 5%. So that is nice to see in the first year. That's not a huge change, but good to see. But we've also seen some changes around food manufacturers and minimal changes on the other different categories there. But that's at least a hint at a positive piece. Have you ever heard of the food environment? You'll remember that I said only 1 in 4 had heard of it at the beginning of our campaign, and that has remained static. So we have not yet had an impact on that. So you can see how complex this is. Understanding the food environment is really difficult for people. The good news is, though, of those, when we split them into those who had seen the campaign versus those who hadn't, that went up to 32%. So if people have seen the campaign, they're more likely to have heard of the food environment. Do you think the food environment positively or negatively affects food choices? So here you can see that there's an increase in the positive, and of course the food environment can positively and negatively affect food choices. So people understand that it's gone up both for the positive effects and for the negative effects. And do you think the food environment positively or negatively affects the health of children? Here we have seen a slight increase in the positive effects and a slight decrease in the negative effects. And of course, that's the opposite of what we would want to see. The main thing is that the majority of people do understand that the food environment negatively affects the health of children. And would you like to see changes made to the food environment? And that hasn't shifted at all really from 24 to 25, so still up there at 72 or 71%. Who should make changes to the food environment? In year one, retailers and supermarkets came up top, and in year two, it's the government that comes up top at 55%. So small changes across the board there, but the key influencers, if you like, are still there in the top 5. Okay, so I think you'd summarize that as lots done, plenty more to do. I'm going to move on to citizen engagement because this is some work that we have done this year to involve the public in helping us decide on the direction of our campaign as we move forward and the key topics that we will engage with. Citizen engagement work allows us to go out to the public and get their input on key issues of concern for collaborative development of policy, and to help build trust with government agencies. And having a diverse groups involved helps us have a more inclusive, legitimate and effective policy and campaign as we move forward. So we've worked with 15 groups and carried out workshops across the island to elicit their input. And what we did was we heard people's views on today's food environment, and we co-created a shared vision of a healthier food environment for the future. We talked about what the problem is now, the biggest barriers, the biggest challenges. We asked participants to imagine a future, that could make a tangible difference. And then we asked them, how do we get there? How will we have the biggest impact? We based our food environments on the WHO definitions and translated them for the public into language that is more understandable. So these included food shops, eating out, food delivery, food ads, public spaces, and food on the go. And we asked them for their input across a number of different food environments and collected all of that data as we went through. The way we collected the input was visual. So we had an artist, a resident artist as part of our program, who created these beautiful images of what the food environment meant for people. So anything from that, mega store of temptation to kids making their own food and lunches. So people had lots of different ideas about what they wanted the food environment to look like. And we also had a photographer so that people could also be captured, showing the kind of food vision for the future that they wanted. And that will become an exhibition in January and February this year, with one in Belfast and one in Dublin. We think we're still working on the dates. And that again will give us an opportunity to talk within the media about the food environment, what people want and what's important about the changes that we need to see. And I'll leave it there, Sarah. Thank you.
Great. Thanks a million, Aileen. I'm really looking forward to seeing what comes out of that work and the exhibitions. Again, really exciting, and picking up on a lot of the themes from throughout today. That piece around working with people where they are, understanding their environments, leveraging that creativity and energy and insights that people have around their own lives and how they live. So thanks a million, and great as always to see the work that you're doing. Just to say thank you very much to, as we wrap up here now, to all our contributors today, to Geraldine, Catherine and Sinead from the earlier session, and Abby for chairing it, and the second half of the morning, Kylie and Karen, Aileen, Abby again, and Fiona. It's been a fantastic fun session altogether. Thanks a million to everybody who joined today and who stayed. Our attendance has been very consistent across the morning, and lots of engagement in the Q&A. So I hope you all found it interesting and definitely got some insights to take away. A big thank you to my colleague Veronica, who is in the background here and who coordinated the event for us, and to colleagues in IMS. So just to say thank you once again. This is our 2025 annual learning and sharing event. As Abby referenced earlier, it's becoming a feature in our annual calendar. So yeah, we look forward to being here again with you next year. Thanks very much, and I hope you have a lovely rest of your day.